So thank you for inviting me. I think it's a return performance, first one maybe since the pandemic, so that's kind of nice. And today I'll be speaking about understanding laboratory and radiology results. Many of you may have noticed that rheumatologists like to send labs and like to send you for radiology visits, but there's a lot of good reasons why we do this, and that's what I'm going to approach today. So why do we send laboratory results? There are a couple of reasons. One, sometimes it helps us in the diagnosis of rheumatoid arthritis or spondyloarthritis. They can also help us to decide or determine how active a disease is, because that can help us make determinations about treatment. Also, we have to check labs because of the potential toxicities of some of our medications. And so there's usually a certain schedule that we follow depending on the medication to make sure that everybody is safe. So in terms of rheumatoid arthritis and spondyloarthritis, the first thing I wanted to address is, well, how do we diagnose the disease and how do labs and radiographic studies help us? Well, first of all, most important is really the history and the symptoms that you provide for us. We pay attention to the quality of the symptoms, how long you've had the symptoms, exactly which joints or which body parts are involved. Physical exam, of course, is very important. So in rheumatoid arthritis, we're looking at we're examining your joints, we're seeing which are swollen, which are tender. We do that for spondyloarthritis as well. Unlike rheumatoid arthritis, spondyloarthritis patients often have low back pain, and so there's a lot of focus on that. Blood tests that we might include when we first see a patient. Rheumatoid factor, that's specific to rheumatoid arthritis. Another blood test called the anti-CCP antibody, also specific for rheumatoid arthritis. And then there are inflammation markers, the ESR, which stands for erythrocyte sedimentation rate, the C-reactive protein, or CRP. These are relevant for both conditions, rheumatoid arthritis or SPA. I'm going to say SPA to shorten spondyloarthritis. And then there's a unique blood test that we check for people with spondyloarthritis, which is a gene called HLA-B27. And I'm going to explain what all of these are in the next few slides. In terms of radiographic studies, we employ X-rays, we employ MRI, and ultrasound most commonly. So in terms of who do we evaluate, who do we decide should be evaluated, I'll focus first on rheumatoid arthritis. So it's patients who have at least one joint, usually with swelling. And we call this synovitis. It could be tenderness and or swelling, with the synovitis not better explained by another disease. So for example, some of our patients are already in their 50s or 60s. They may have developed a different type of arthritis called osteoarthritis, which is, if you will, old age arthritis or arthritis that we get as we get older. And so we have to decide what condition we think a patient has in terms of whether we're going to start testing for rheumatoid arthritis or spondyloarthritis. Focusing first on diagnosing rheumatoid arthritis, this is just a basic way that we think about it as rheumatologists. And we don't necessarily have to fulfill all these criteria, but I think it's useful to show you this schema because it explains how the rheumatoid factor and the CCP, as well as the inflammation markers, come into play. So first we look at the joints, and we can assign a certain level of activity depending on how many joints are involved. So you can see here that if you have 1 to 3 small joints, we think of this as being equal to 2 points. Over 10 joints gives you 5 points. And if you have more than or equal to 6 points, then we're fairly confident that you have rheumatoid arthritis. Having said that, this is important if we're including patients in a study, but on a clinical basis, in clinic, you may not be aware that the rheumatologist is even thinking about this. Rheumatoid factor and CCP, these are the antibodies that we see a lot in rheumatoid arthritis. And again, depending on whether you have one of these positive, both of these positive, we assign a certain number of points. Similarly, the CRP and sedimentation rate also play a role in considering whether you have rheumatoid arthritis. And then finally, the duration of symptoms. Most patients with rheumatoid arthritis will consider the diagnosis after 6 weeks of chronic symptoms. Turning to spondyloarthritis, this is the schema that we use in considering whether a patient may have spondyloarthritis. So many of our patients come in with low back pain. Now, 98% of us will have low back pain at some point in our lives. We think about SPA when the back pain has started before age 45. And we also think about it when it's present for more than 6 months. We also think about it if we happen to already know that a patient has this gene, the HLA-B27 gene. So what is shown here is that in somebody with back pain lasting more than 3 months who is relatively young, we're going to get x-rays or other imaging, MRI, to see whether they have any findings of SPA. We're also going to get this HLA-B27 gene, and then we're going to consider other SPA features, other symptoms that somebody with SPA may have. And it's a combination of all of these factors that leads us to the diagnosis. Let's go back now to some specific details about these blood tests. So first, I'm going to talk about the rheumatoid factor, which, as I said, we check in patients with rheumatoid arthritis. So this is an antibody. We all have antibodies in our body. When we are exposed to any kind of infection, we make antibodies. In the era of COVID, we know about this. This is how we're tested potentially if we've had COVID, or if we've gotten a vaccine. Sometimes our antibodies are checked to see if we responded to the vaccine. The difference between those antibodies that we need to fight infection and a rheumatoid factor is a rheumatoid factor is an antibody that's directed against our own body. It's not directed against COVID, or it's not directed against a bacteria we might be affected with. And that means that it's an autoantibody, auto meaning self. So it's an antibody against one's own self. Important to know that a rheumatoid factor is not positive in all patients with rheumatoid arthritis, 80%, which is a lot, but 20% don't have rheumatoid arthritis, and that's also don't have rheumatoid factor, and that's also a big number. Also, I want to highlight that despite its name, rheumatoid factor, it's not unique to rheumatoid arthritis. It can be found in many different conditions, infectious disease, even malignancy, other autoimmune diseases, and sometimes we see a rheumatoid factor in people who are completely healthy. The other antibody that we see in rheumatoid arthritis is this anti-CCP antibody, long name, anti-cyclic citrinolylated peptide. And this antibody is positive in fewer patients with rheumatoid arthritis, 60 to 70%. But in contrast to the rheumatoid factor, it's much more specific to rheumatoid arthritis. So that means that in the majority of cases, patients who have this antibody being positive are more likely to have rheumatoid arthritis than not. Both antibodies can decrease with effective rheumatoid arthritis therapy, although anti-CCP tends to decrease less. It tends to remain positive. Sometimes we see these antibodies even before somebody has rheumatoid arthritis. So somebody may have a pain and an internist decides to send the antibodies and they're positive, and people are sent to us, and we may say, you know, you really don't have any findings or symptoms of rheumatoid arthritis right now, but having these antibodies may predict that you may develop rheumatoid arthritis in the future. We have seen that in people who have the CCP antibody, especially if it's high titer, it may predict a more aggressive course of disease, but that's not 100% in all people. I've seen people who have high titer antibody who never develop aggressive disease, and the opposite is true as well. Now I'm going to toggle back to ankylosing spondylitis and this blood test that I mentioned, the HLA-B27. So this is a normal gene. We all have HLA-B genes. We get one from each of our parents. So somebody may have B7 and B12, somebody else may have B56 and B21, but there is this HLA-B27 that some of us have. And there was a study looking at the population in the United States to see how common is this gene. So in non-Hispanic whites, Caucasians, 7.5% of the normal population have this gene. So that's a lot of people. If Mexican Americans were included in this study, so fewer Mexican Americans have this gene, that's 4.6%. And then we have non-Hispanic Blacks. The smallest percentage of patients have this, 1.1%. But what we see in patients who actually have SPA, meaning they've come in with low back pain and we've determined on x-rays and radiology that they do indeed have this condition, 90% of those patients have the gene. So there's something about having HLA-B27 that may increase your risk to getting that condition of spondyloarthritis. Again, not the majority of people. So if you happen to have the HLA-B27 gene, about 1 to 2% will develop spondyloarthritis. So I make this point to say, even if you have this gene, it doesn't mean that you're destined to develop the condition. The sedimentation rate and the C-reactive protein. So these are both nonspecific markers of inflammation. They can be elevated in many different conditions, including autoimmune diseases such as rheumatoid arthritis or SPA, but they're also elevated in other conditions such as infection. And then sometimes we see people who have elevations in these inflammatory markers and they don't have any disease. So a little bit nuanced in how to interpret them. We do follow in patients who do have an autoimmune disease such as RA or SPA. If a patient has elevated levels of one or both of these markers when their disease is active, we then can check them intermittently and see if they've responded to our treatments. But it's important to know that some patients never have elevated markers, even if they have a lot of disease. And some patients have markers that are always elevated, even if their disease seems to be very well controlled. So in other words, different individuals have different pattern. And what's most important to any individual is a patient is what his or her pattern is. I'm going to turn now again to rheumatoid arthritis just to show you how the sedimentation and C-reactive protein may play a role in assessing the disease. So one of the tools that we use when a patient comes in to see us is this tool called a DAS28. It's a form, and many of you may have encountered the form. And I'll show it to you in a minute. So the form has 3 components. 28 refers to the number of joints that I, as a physician, will examine. And I'm looking to see whether the joint is tender and whether the joint is swollen, and I'll be documenting it on the form. Then we have a visual analog scale, that's the second component, in which we ask you on a scale of 0 to 100, how much pain and stiffness have you experienced in the past week? Patients hate this question because it seems somewhat arbitrary, but if it's asked consistently between visits, we do sometimes see trends. And finally, we include the sedimentation rate or the C-reactive protein in making this calculation of a DAS28 score. So this is the form, and I don't know how well you can see this, but basically this upper part just talks about the different joints we check, the shoulder, the elbow, the wrist, all the joints of the hands. And we tally here how many joints are tender, how many joints are swollen, and then we add those up. This is the visual analog scale, or sometimes I just say to my patients from 0 to 100, how much pain and stiffness have you had in the past week? So this number is also included. And then we include the sedimentation rate or the CRP. And a computer will spit out a score for us. So if the score is very high, if it's over 5.1, this correlates with high disease activity. If the score is low, less than 2.6, that correlates with being in remission. So I mentioned this just to show you how the sedimentation rate and the CRP help us in following patients and assessing their activity of disease. In spondyloarthritis, we don't use that form. Again, there the focus is often on back pain, not always. And so these are the set of questions that we use for back pain. And it includes fatigue. It includes how much pain are you having in the past week? How severe is the pain? Any areas are tender to touch? How long, if you're stiff in the morning, how long does it last? And so all of these factors are included. So you notice it's different than swollen and tender joints that we were talking about in rheumatoid arthritis. And then also included in this, again, is the sedimentation rate and the CRP. And similarly, we get a score and we decide how active a patient's disease might be. Now, there are other antibody tests that we sometimes check, and you may encounter these in your blood tests. So more for rheumatoid arthritis and SPA. There's an antibody test called the ANA, or the anti-nuclear antibody. There are tests called anti-Rho or Sjogren's syndrome A and anti-LA, Sjogren's syndromes B. So some patients with rheumatoid arthritis may also have these tests that are positive. These particular Sjogren's antibodies, some patients with rheumatoid arthritis will develop with their rheumatoid arthritis a condition called Sjogren's, which causes dry eyes and dry mouth, amongst other symptoms. And so it might be informative to check these and see if a patient is positive. Very commonly, we check the comprehensive metabolic profile. And this is your routine lab test. It includes liver function, kidney functions. It includes electrolytes levels like sodium, potassium. And since some of our medications can affect liver function or kidney function, it's important to check these at baseline. And then if a patient is on a medication, to follow these every 3 months usually. We also check a complete blood count. So this includes the white blood cell count. It includes the hemoglobin and hematocrit. It includes the platelets. 2 reasons to check this. Some people with inflammation will have elevation, let's say, of the white blood cell count. Some people with autoimmune disease may have mild anemia, so the hemoglobin and the hematocrit may be low. Sometimes platelets are affected. Often, both these sets of labs are completely normal. And the reason we're checking them from time to time is, again, because some of our medications might affect the white blood cell count or might affect your hemoglobin, hematocrit, or platelets. And so we want to make sure that we monitor them. And in that case, we might alter the dose of the medication if we see any toxic effects. I'm going to move now from laboratory tests to radiographic studies. And the radiographic studies that we usually employ are X-rays, MRI, and ultrasound. In rheumatoid arthritis, we use X-rays to look for classic findings of the condition. So you might come in with swollen and tender joints, and the X-rays might give us a little bit more information about what's going on. Also, because things can evolve over time, it's important to get a baseline. So classic findings of rheumatoid arthritis are joint space narrowing, and particularly in certain joints, let's say we're looking at the hands, you have 3 sets of joints in the hands. There are joints, I guess maybe you can see, there are joints right under the nails. These tend not to be involved in rheumatoid arthritis. There are these joints in the middle of the fingers, and then there are these joints that attach the fingers to the hand. These are the joints that we're particularly looking at in rheumatoid arthritis, and we're also looking at the wrists. Reason being that these joints are commonly affected. So we're looking to see if there's narrowing. Narrowing suggests that some of the cartilage may have been eroded. We're looking to see, sometimes we see some bone loss around the joints, and so we're looking for that. And then as our disease advances, which we're hopefully, hoping not to have happen because our medications do prevent progression, there are erosions, which means that there might be a tiny little defect in the bone surrounding the joint. So here I'm showing a hand X-ray, and these 2 joints, these are the joints that are at the bottom of the fingers right here. These are called the metacarpal phalangeal joints, or MCP. So the arrow is pointing out just kind of this little mouse ear here at the periphery of the joint, and here's another one. That's known as an erosion. And I like this X-ray because right here, we don't see that little bite mark at the edge of the joint. So this is what a joint should look like, normal, and it doesn't have any of these bite marks. And this is a rheumatoid arthritis erosion. We also might use ultrasound. So what are the advantages of ultrasound? So ultrasound uses sound waves rather than radiation. I mean, X-rays are very low radiation, but ultrasound doesn't have any. The advantage of ultrasound over an X-ray is that we can actually see inflammation within the joint. So sometimes somebody may have a tender joint. We're not sure that there's swelling in the joint. Doing an ultrasound may actually show us whether or not there's any fluid or other type of inflammation within the joint, something an X-ray can't show because X-rays only show bone. And also we can use a technique called Doppler, which can show us whether there's blood flow through that joint. An inflamed joint will have blood flow coursing through it, and I'll show you a picture of that. Ultrasound can also be useful if you need to take a little bit of fluid out of a joint to be tested, and that can be done at the same time as the joint is being evaluated. And unlike X-rays, which don't show us the soft tissue of the joints, around the joints, in addition to the cartilage in between the bones, there are tendons, there are ligaments. Ultrasound evaluation can actually show us the cartilage and the tendons, which can be helpful. Disadvantage of this technique, it may be overly sensitive. So sometimes the ultrasonographer will say, oh, I see a little tiny erosion here. I don't really know what it means. And also it's relatively new, as not so new anymore, but ultrasound of the joints came much after X-rays of the joints. And so if we see a little tiny erosion, we don't really know if it's significant. We may find just as many in a normal joint. So all of that research is being done now so that we understand what is significant and what is not. So here I show you, this is actually a finger joint. It's that same joint where we saw an erosion before. And so this is the actual joint. This is the cartilage. And what we're seeing here is all of these pretty colors. That is the blood flow I was mentioning. And this indicates that this is indeed an inflamed joint, something that we can't appreciate on the X-ray. This is now an MRI. MRI is also much more detailed and much more sensitive than an X-ray. So this is a wrist, and this is the back of the hand. And here again are the MCP joints. And here you see that the bones are white. There's this dark area here, and that's an area of inflammation and also perhaps an erosion. And here's a very subtle finding here. This is a different way to look. You notice now that it's the bones look black, but now the fluid that's in that area is white. So it's easier to see actual fluid representing inflammation in this type of view rather than this type of view. And this might or might not be visible on X-ray. So sometimes doing an MRI, if we're not sure how aggressive the disease is, an MRI can give us that information. In terms of spondyloarthritis, again, where the focus might be more on the back, there's a particular portion of the low back that we're interested in spondyloarthritis. And this area is the area known as the sacroiliac joints. They're at the lower back, and these are two joints that link the lower part of the spine, the part called the sacrum. If you feel down low of the spine, there's this kind of solid area way at the bottom, which is the sacrum. And the sacrum is next to the top part of the pelvis in the back, and that part of the pelvis is known in the ilium. Between the sacrum and the ilium are the sacroiliac joints, and you can see why they were given this name. So classic findings at the sacroiliac joints on X-rays are to see erosion, similar to the erosions that I showed you in rheumatoid arthritis, except now they're not in the hands, they're at those joints in the back. And sometimes we also see sclerosis, which means a thickening of the bone around the joints. I just show you this picture because people are not as familiar with, what's going on in their back. So here we're looking at the front of this woman, and here's the pelvis. This is the portion I mentioned that's called the ilium. This structure in the middle is that sacrum, that solid piece of bone at the bottom. Here are the vertebrae. And then this is the sacroiliac joint on either side between the sacrum and the top part of the ilium. And this is what it looks like on X-ray. So just quickly, this is a normal sacrum with normal sacroiliac joints, and here they are. And I'll be very honest with you. I depend a lot on my radiologists to read these because The findings can be subtle. And fortunately, we're very fortunate at HSS that our radiologists see a lot of these and they're very expert. And so I'll often call to review the x-rays with our expert radiologist, so I have a better sense of what's going on. This is an MRI of the sacroiliac joints, and now here they are. Okay, so here's that big structure called the sacrum. This is a piece of the ilium, and the joints are here in between the sacrum and the ilium, and these are actually normal. I'm showing you this side by side because here you can see this is normal, but here you see this area of white around the joint. And it's hard for you to tell, but this joint is actually narrowed. And what this area of white represents is inflammation. It's edema around the sacroiliac joints. And this is what we're looking at or looking for to try to make a diagnosis of inflammation in the sacroiliac joint, which suggests a diagnosis of spondyloarthritis. So in summary, we'll have lots of time for questions. Rheumatologists use blood tests and radiographic tests to diagnose rheumatoid arthritis and or spondyloarthritis. And the specific labs we spoke about were rheumatoid factor, CCP for rheumatoid arthritis, HLA-B27 for spondyloarthritis. And we also use lab tests to follow patients for disease activity. And that's where the sedimentation rate and the C-reactive protein came up, as well as medication toxicity. And that's where we talked about the CMP, comprehensive metabolic profile, and the CBC, the complete blood count, to look for any evidence of liver, kidney, or hematologic toxicity. Fortunately, when we see any evidence of that, we can stop the medication, everything reverses, we can alter the dose and move on. Important to remember that patients with rheumatoid arthritis or SPA can sometimes have completely normal blood tests. And in that case, what we're depending on to make the diagnosis is the history, the quality of the symptoms, the length of how long you've had the symptoms, and very importantly, the exam and also the radiographic studies. In a seronegative situation, meaning that the blood tests are normal, the diagnosis can be made primarily by the clinical picture, the history, the physical exam, which is just repeating what I said before. And then the radiographic tests that we reviewed can also help in the diagnosis. Also, over time, we might repeat some of the radiographic studies because they can either confirm that things are stable and nothing is progressing, or sometimes if we see that there's progression, that would dictate that we change our treatment. And I'm finished, and thank you so much for your attention.